All right, in this video, typically when I document things, I'll say soft tissue mobilization to posterior lateral cervical muscles, okay, as like this general thing. What I mean by that is, and it's not totally accurate because we're going to look at scalenes, anterior, middle, posterior. We're going to look at SCM, and we're going to look at upper trap and levator. And I kind of assess all of them and just see which ones are the most important in this moment to work on. But some people I work on all of them. Other people it's, one or two or whichever one feels like the most important thing. So typically for this, I will start on the SCM, right as where it attaches into mastoid process, right? I will grab the front and back of it and I will just kind of spring test it forward and back. Oftentimes with people that have SCM dysfunction, it's kind of the head is in this forward head position, right? And so oftentimes the SCM is limited in its ability to go down towards the table. And so I'll feel left versus right, and I'm interested in, let's say that I'm interested in this right side going down towards the table. Now I will grab SCM and kind of do a twisting motion. So I could either grab it and twist my top thumb away from me, or I could twist it back towards me. And I do both. My intention is a counter force with the bottom finger as well. And so in this case, like many cases, it's more restricted pushing down towards the table. Okay, so I could work on it there. I could have her lift her chin up, tuck her chin down, breathe. Good. I could have her take her hands up towards the ceiling and reach long through her shoulder blades and do a little scapula, and that brings a little more tension in. And I'm just continuing to stay on that localization from a SCM standpoint. So SCM, really, I do a lot of treatment with that from a muscle bending technique. That's what I'm doing, grabbing the muscle and kind of bending it one direction versus the other. Now, we have anterior scalenes, which attach from C3 through 6, I believe. And then they go to the first rib. So transverse process, C3 through 6 to the first rib. You're going to access those just kind of in front of the SCM, which drops down. And so I just typically, this can get nervy on people, so you want to make sure that they're not getting numbness and tingling down the arm. But I will sink in to scalene, and then I will just try to find the hard infill. In this case, it is kind of scooping down in this direction. And a lot of times I'll just do breathing with SCM work and out because I don't want to get too aggressive, because again, if SCM is really hypertonic or lack of muscle play, oftentimes the nerves are going to be somewhat irritated or easily irritated in that area, and we don't want to do tons of stuff to reproduce numbness and tingling down the arm. If they do get a little numbness and tingling down the arm, I'm not thinking I can't work on it. I just want to come off of that. If it goes away within 10 seconds or so, I'm good with that. I want to see though, is there an option for me to engage that infill without the radicular symptoms? And if there is, great, let's do that, less aggressive. If not, as long as it goes away within 10 seconds, we can continue to kind of work through that. But again, we're not trying to flare them up. Now going to middle scalenes, we'll go just behind SCM, right? Middle scalenes is the broadest attachment point, so it's like C2 through 7, I believe. And so anywhere kind of between here and here, there's going to be middle scalenes. All right, so I'm going to feel if I sink in, and again, most of the time the infill is going to be in some direction down towards the table, because people that oftentimes need this, their ribs are pulled up and then their shoulder blades are kind of relatively pulled forward, and we want to get all of these soft tissues the ability to move kind of down towards the table so the head can get back in a better position over the shoulders. So now if I'm getting in on SCM, I'm just feeling along, if I'm getting in on middle scalenes, I'm going just behind SCM along the muscle belly, and I'm just kind of doing a little perpendicular formation technique down towards the table. And right here at probably, I don't know, C3 level, it feels restricted. So I'm just going to localize through the head there, and then I have all of my functional mobilization options. Okay, so that's kind of more middle. And then posterior attaches from C5 to 7 down to rib 2. And so I know to get on posterior, I need to be lower down in the cervical spine. And again, oftentimes to get perpendicular deformation here, I'm actually kind of coming down on this angle, kind of towards her opposite elbow or opposite hip. And then I'm just searching for a hard infill there. And then localizing through the head to get a good perpendicular deformation. Again, scalenes, a lot of times I'm just using breath. So go ahead and breathe in there. Good, and breathe out. Good. And a cover position would be another good option for posterior scalenes. Okay, so now we have levator. So I learned somewhere along the way that levator, 50% of the fibers attach up onto C1, C2, and then it attaches kind of throughout the cervical spine, and the other end of it is this superior medial angle of the scapula. I would say when my intention is on levator, I focus on that superior medial angle of the scapula, and I will have people go into more of a lazy cobra position here. Relax your head down to start though, Kelsey. And so I like to kind of sink through upper trap, intention onto right where the muscle attaches onto that superior medial angle. I will pin it down towards the table there, have her nod her head a little bit and raise her head up on a diagonal away. That's it. And she had a little positive squinch test there as she came up and then down. And I don't want her to blow through that pain. So I just want her to go up to where she feels it and then back down. Yep, and you can go up and down there. Good, and then good. And then you could pair that with breath work as well. Like you could have her breathe in as she comes up and out as she drops back down. And I'm just, again, trying to get that perpendicular deformation. Or you could even think of it as a broader technique on levator where you're kind of like pushing that levator down towards the table of a muscle bending technique as well, okay? So that's kind of how I'll treat levator. You can also strum levator right at the attachment point into that superomedial angle. There's just a lot of soft tissues in that area, and if you can get them to kind of separate on each other, everything can kind of functionally lengthen in a happier way. Finally, upper trapezius, you'll hear the trend here. I'm trying to get everything to go kind of down towards the table so that the head can go back in a good position. So I will come all the way out in upper trap where it attaches all the way basically close to that AC joint and spring test down away from the clavicle here and just see where along that upper trap does it not want to move down towards the table. I can check one side versus the other. For Kelsey here, it's probably right at kind of in that level of where her first rib kind of comes around that it's most restricted. And so some people, depending on how large their upper trap is, most people have a relatively large upper trap because we overutilize this muscle oftentimes. You may be able, I can't on Kelsey, but you may be able to get in with the heel of your hand and just kind of sink down into it with some of the more muscle-bound people that need this. And then with those people, what I'll do is have them just kind of rotate away. I may bring them up into a little bit of lazy cobra. With Kelsey, I feel like I can get on with just my fingers here, and then I can have her side bend away, right? Going on pressure, off pressure there. I could also have her go towards her opposite armpit. That bias is typically a little bit more levator, but then if I kind of start to rotate the head back in that position, then upper trap really starts to come up into my hand. So breathe in there. Good, and breathe out. And I can just see if I can get that trap to drop down towards the table. Also great muscle to do a little dry needling in if you do that. So That is kind of a general overview of upper trap, levator, SCM, and then all of the scalene soft tissue approach.